Putting a stop to CAUTI in the ICU at St. Catherine's Hospital. Healthcare-associated infections affect 5 to 10% of all hospitalized patients each year in the United States and account for nearly $45 billion in direct hospital costs and cause nearly 100,000 deaths annually. Catheter-associated urinary tract infections, or CAUTI, is one of the most common HIAs in the United States and is reasonably preventable. Our ICU's CAUTI's rate at the start of our project was 8.5. We wanted it to 0. CAUTI can cause discomfort, prolonged hospital stays, increased cost, increased antimicrobial use, and mortality. The U.S. Department of Health and Human Services set targets in 2013 to reduce CAUTI nationally by 25%. Progress reported by 2014 showed worsening CAUTI rates. And to meet the new target set for 2020, more action is needed. After assessing my ICU, it was easy to see that the healthcare team was not collaborating effectively to reduce CAUTI. Our patients in the ICU are at a significantly higher risk for developing an HIA. We had a nurse-driven protocol in place, and for the most part, our MDs supported nurses using it. One of the reasons we had this nurse-driven protocol is because too often doctors forgot the patient still had an indwelling urinary catheter, and then there was a major delay in its removal. Although we had this protocol, very few nurses used it. Each day the urinary catheter remains in place, the risk of a CAUTI increases by 5%. Between 15 to 25% of hospitalized patients receive a urinary catheter during their hospital stay. And the most important risk factor for developing a CAUTI is prolonged use of the urinary catheter. Therefore, catheters should only be used for appropriate indication and should be removed as soon as they are no longer needed. Based on the CDC recommendations to reduce CAUTI, I wanted to empower the bedside nurses to be leaders, to use the guidelines, the protocols, and our nurse-directed orders to remove unnecessary catheters. I assembled a team made up of staff nurses, the infection control nurses, my nurse manager, the education nurse, and the director of the ICU. We all were committed to finding a way to decrease our current CAUTI rates. It was important for me to choose a team with members that were as driven as I was. I also wanted to pick people who were knowledgeable and could be a resource to me during this entire process. We decided our project aim was to reduce CAUTI in the ICU at St. Catherine's to 0 by reducing the use of indwelling urinary catheters, by implementing evidence-based practices including catheter rounds, education, and offering reliable and available alternatives to indwelling catheters by May 6, 2018. Our hospital already has plenty of indwelling catheter insertion and maintenance training, so we decided our goal was to change the culture surrounding the indwelling catheters. We realized that trying to change the way nurses have been practicing for so many years was not going to be an easy task. We wanted the nurses to break up with these dependence on the urinary catheter. On average, in the ICU, about 60% of our patients have a catheter. We wanted to reduce that number to 30%. The nurses on the team and I did a lot of research on ways to promote change and increase nurse buy-in. The way evidence-based practice is disseminated affects how it is adopted. We wanted to impact all the staff nurses in the ICU. The goal to achieve sustainable CAUTI reduction and catheter use through the implementation of evidence-based culture improvements, CUSP, and application of the Center for Disease Control guidelines for prevention of CAUTI. Before we initiated any changes, we wanted to collect baseline data for 2 weeks. Our process measure was the indwelling catheter usage rate, which we figured out by adding the total number of catheter days and dividing it by the total number of patients and multiplying that by 100. Our outcome measure was the CAUTI rate, which we figured out by using the number of symptomatic CAUTIs in the ICU and dividing that by the number of indwelling catheter days in the ICU and timesing it by 1,000. We then began the PDSA cycles. We started with education, and lots of it. The goal of our education was to make CAUTI the in conversation, to put it back into the spotlight. Our goal was to have no cowties, to have the staff be a part of the change. So we listened to the staff and made learning fit into their schedules. We all understood that nurses are busy, so we held in-services during lunch, and we did powwows at their wows and made pocket cards that they could hang from their ID badges with catheter algorithms on it. We arranged for representatives from the Condom Catheter Company and the PureWick Company to come and speak about their products and give nurses hands-on learning. There was no additional cost for providing this education for the staff, but the return on the time investment could be high. Interventions yielding clinical feasible reduction in catheter use can lead to an estimated 50% reduction in cavity-related costs. As of 2008, Centers for Medicare and Medicaid Services stopped reimbursing hospitals for the additional cost of caring for patients who develop cavity during their hospital stays. It has even been estimated that costs associated with patient diagnosed with cavity are twice as much as the patient not affected by cavity. That being said, I am a staff nurse, so I understand the struggle of having an incontinent patient who is critically ill. So my goal was to re-educate staff on alternatives to indwelling catheters, such as condom catheters, and proper sizing charts and how to use them. We worked with the storeroom to make sure that the PAR for our condom catheters and our straight catheters were increased. We initially hoped to be able to trial the new female non-indwelling catheter called the PureWick, but our trial has been delayed till this summer. The next phase of our project was catheter rounds. The ICU manager, the ICU director, the infection control team, and myself all rounded on each patient in the ICU. We evaluated each patient to determine if they had an indwelling catheter, and if they did, we then had a conversation with the nurse assigned to that patient about that patient and any indications for them still having the catheter, or could it be discontinued and an alternative option, or maybe an alternative option was feasible. We continued to spread the change by continuing these rounds weekly, and as time went on, we started to see a shift in the culture when the nurses began leading the way and advocating for fewer catheters and promoting earlier removal. As a result, we were on our way to zero cavities. The rounds also helped to bring the team together and collaborate and give the bedside nurse a sense of power and accountability. We wanted to keep the staff engaged, so we offered different education weekly during our lunch and learn or powwows. We also felt it was important to provide regular feedback to our staff on our progress. So we displayed our catheter rates and days without a cavity rates weekly, and we celebrated our successes to promote buy-in. We noticed that the night shift was not engaged enough, so we adjusted and specifically offered education during the evening shift to capture the entire ICU team. We also faced barriers with a handful of ICU nurses that refused to believe in the project. They were stuck in a long-term relationship with indwelling catheters. To move past this, we decided to press on and continue to show positive outcomes and promote change to those who would listen. We hope that as time moves on, these laggers will eventually see the light and jump on board. By the end of our 12 weeks, we did achieve our goal of zero cavity in the ICU. But we did not reach our goal of decreasing indwelling catheter usage to 30%. Although for this short period of testing, we were not really surprised. We plan on continuing this quality improvement project to reach our aim and sustain changes. The hope is that the addition of the PureWick female non-indwelling catheter will increase nurse buy-in to our project and promote change farther. This project impacted nurse practice in my unit by beginning to change the culture regarding catheters. I began to see nurses evaluating catheter placement more often instead of having the mindset that all ICU patients have to have an indwelling catheter. With effective communication and teamwork, we were able to empower nurses at the bedside to be leaders and improve patient safety by embracing elements of the CUSP model. When the healthcare team was able to collaborate and focus on patient safety, each staff member began to hold themselves accountable for decreasing cavity in our ICU. Future endeavors should include tailored education for the emergency department. If we collaborate with the emergency department, we could lower the initial catheter insertion rates and sustain zero cavities and lower catheter prevalence rates. To sustain our improvements, we need continued multifaceted interventions combining best practice guidelines, staff engagement, education, and continual monitoring of IUC rates along with CAUTI rates.